So at this time, it's my pleasure to introduce Dr. Monica Beaulieu. Dr. Beaulieu is the Division Head of Nephrology here at St. Paul's and the KCC lead here at St. Paul's as well, and the KCC lead provincially for the BCPRA. So welcome, Dr. Beaulieu.
So thank you for the invite. I'm thrilled to be here. Thanks to the transplant group for asking the KCC group to be part of it, because I hope in the next 20 minutes or so to describe to you the fact that KCCs really are pre-transplant clinics and should be pre-transplant clinics. So I'm really here on behalf of the KCC provincial group, of which many of you are on. So this is really all on behalf of what is being done in BC. We're going to talk a bit about current stats with respect to preemptive transplant from the kidney clinics in BC, just a little bit, because I know that comes in other talks. We're going to talk about what we tell people in the KCCs about transplant education. We'll talk a bit about the referral process from the kidney clinic side. And then we'll talk a bit about how to ensure and maintain sustainable education of the kidney care clinic providers. We've done a few surveys recently to assess needs, and this meeting is facilitating some of those needs, but we'll talk a bit about how to maintain those. So this seems a bit like an intuitive statement. Preemptive transplantation is the gold standard renal replacement therapy choice for people with end-stage kidney disease who are clinically suitable. And that really is the motto of the kidney care clinics. Can I just ask, how many of you work in KCCs? Most, okay. And so for people on the line, it's over half. How many of you had a hemo background or a PD background before? Okay. And how many of you were transplant nurses before you did KCC? 0. Yeah. So our KCCs are staffed with people that have a wonderful understanding of PD, of hemo, of home-based therapies. But we haven't had that interaction as much with nurses that come from the transplant programs. And I think that's something that we can work to try to make sure all of us in the kidney care clinics are as informed as we have to be. So this is the only slide about the benefits of preemptive living donor transplants, because Dr. Johnson after me will explain the nitty-gritty of the benefits. But I guess the 3 bullet points to take home is that preemptive living donor transplants do save lives. They improve a patient's quality of life. And our kidney care clinics are aiming to promote a transplant-first approach. We've heard about fistula first. We've heard about home-based therapies first. We want to keep those in our minds, but kind of change the dynamic to transplant first. And it's an unspoken thing that it is transplant first, but I do think in all of our clinics, if we step back after this day, I think there are some processes we can put in place, some learnings to really make our kidney care clinics a transplant first clinic. There's been so much emphasis on preparing patients for renal replacement therapy, having the right preparation, having the right modality, ensuring conservative care discussions, which are important regardless, but this is what we're trying to bring to the forefront. So just to remind you who we are, we have 13 clinics and we follow about 10 to 12,000 patients in kidney care clinics. Of those, at any one time, about 2,000 have GFRs less than 20, and about 500 go on to dialysis a year in BC. So starting about 3 years ago, every 6 months, the kidney care clinics put out indicator reports, and I'm just going to share 2 indicators from that report. This is starting from your left from October 2013 to March 2014, and 6-month increments, and the last report hasn't actually been released yet. We just got the data from October 2015 to March 2016. And it shows that about every 6 months, about 250 to 300 patients start renal replacement therapy. And of those, about 7%, pretty average, right? 7, 5, 7, 7.5, 6. We initially thought we were doing quite well because the numbers went 13, 20, 23 in terms of number of patients getting preemptive transplants over a 6-month period. But when you actually look at the denominator, it's about stable coming from our kidney clinics, and about 7% of those starting dialysis will get a preemptive transplant. So I'm sure there's lots of questions in your brain, like what is the denominator? Should it be the 250 patients? those are people that went on to some sort of dialysis. It doesn't include the conservative care. So we're closer to the true denominator. But how many of those patients are actually transplant eligible patients? I think we have some work to do, and this is all new data, right? And it's really exciting to be able to work with transplant and with the KCCs to actually generate this data out of BC. So we were a bit discouraged, but one thing that actually is increasing is the patients with a GFR less than 20 and a modality decision documented. How many of those are choosing transplant as their first modality? And just to remind those of you that don't work in the KCCs, anyone that chooses transplant, it kind of has gone through kind of an initial screen in terms of eligibility. So someone that is absolutely not eligible, if they say, well, I choose transplant, they don't get marked out as choose transplant, some education is provided. Now, also people that choose transplant also all have to have a backup modality. So unless there's, the one or two off that are a perfect match and the donor's there and we don't really, but we still talk about a backup modality because of the need potentially for dialysis in the interim period. So that number is increasing. And so we have about, every 6-month block, about 1,200 patients that have a modality documented. And of that, the percent that have chose transplant as their, yes, that's my number one modality and I'm actually going through the process, has increased from 6 to 9 to 12 to 16.5%. And when you look at numbers, what kind of numbers is that? 6% is about 70 patients. 16.5% is about 250 patients. So as of last week, there were 250 patients in the KCCs that have been initially screened, and I must say our screen is a bit more liberal because we don't want to miss anybody, but initially screened, given education, and want a preemptive transplant first, 250. We did 23. So in terms of the denominator, there definitely are some patients out there. Now, some of those aren't ready for transplant yet. There's a lot of factors. Some won't be eligible once they go through the process. Some won't get a donor. But I would hope that more than 1 in 10 of them can. So I think the opportunity is there. So when we talk about why is that increasing? Why are we doing better? I'm going to try just to change slides to show you a bit about how we educate patients. But just as a start, there is, as of about 3 or 4 years ago, we all did it different. So every KCC had their own PowerPoint presentation that was handed down or something created about what they thought was important for patients to know. And so about 2.5 years ago, we started a quite more lengthy than we thought process to find out, what do patients want to know? What do patients retain when you present it different ways? How, in what format should it be presented? What questions do they still have after? And we worked with a group from UBC that actually were experts in adult education and actually sat into a bunch of, thank you all of you who let the team sit in when you were doing modality education, and wrote down their report, interviewed patients before and after, trialed these new systems, and then did retention before and after. We are just finally rolling it out in all communities with an evaluation now. But I'll just show you, for those of you that just know orientation happens, but doesn't know what happens. I will just show the transplant section. So it's broken up. It's online. It's in several languages now, or becoming available in several languages. It is in a clipboard or a poster board format as well. There's a YouTube video narrated by yours truly that talks it through. There's a script, and so it's quite systematic in the way it approaches it. And you can click on whatever section you want. There's a section on conservative care, on PD, on hemo and home-based hemo, and on kidney transplant. So I won't go through all of it, but just to show you the format and the number of words. Very few words, a lot of discussion. So for kidney transplant, a lot of talking to the patient, a lot of what do you know about it, a lot of what do you want to know about it. Most of these are done in an individual format versus a group. It can be used for either. What is a kidney transplant? The benefits of having one. The possible drawbacks. These are things you know, just to go through what we do. It always surprised me after the transplant discussions that the patients never knew that the kidney went here and their other kidneys stayed in. After 3 or 4 or 5 discussions and they've picked transplant, they didn't, and they were surprised, they were taken aback. You would think it wouldn't matter, right? But these are the things after that the patients still had questions about. Does anything surprise you? What more do you want to know? The kinds of donors. We go to living and deceased. We talk a bit about what living and what deceased is. And then we talk a bit about living and deceased donors to try to, it's really hard to explain people wait lists and when you go on the wait list, and that there really isn't a wait list for living, there is for deceased, but it still takes time. So it's done in a setting of questions. And of course, there's some scripts that go along with this as well. The paired donation program is talked about briefly, as simple as this. Going through the simple explanation of what it is. We do not go into chains, we do not go into other things, we just say there are other options for you if the match isn't right at the first go. The benefits. True or false for some of the most common questions asked and a script that goes with them. Things like the drawbacks of I don't want to have surgery, I don't want to travel for surgery, and you can talk about the different programs that are available. Worrying about the rejection of the kidney, worrying about the medications, telling people about medical support and how it is available. You need a lot of supplies, equipment. So we go through both of them and try to explain why transplant is best. The importance of telling them that it isn't a get your kidney and go. And then reevaluating what do they still want to know. Is this something you would consider? And if not, why not? Because often we go through the different modalities and they hear about it. The patient doesn't really, it's not as interactive as it can be, and you don't hear what the patient's actual, what they've heard from you and what their reservations are after they heard it. So often by just asking them what part of it scared you, what part of it didn't you know, what part do you want further information on, it helps. So it's actually been quite helpful. So what I would be wonderful is if the transplant programs, as new things come up, as you want new information given, we can work together to modify this to, if wait lists go up, if wait lists go down, if you want other information. What we were told time and time again is more information is not necessarily better, and all the principles that you know of adult education. But if there are things that are not correct or new things, the wait list is going down, something that's important, make sure that in BC it's pretty easy to get that change, and then we can push that change out. And you can do that education, of course, before the patient reaches. So when do we do it? So the algorithm for the kidney care clinic is at 25 mils per minute in a patient that is progressive. That is when you introduce the concepts. And by 20 mils per minute, for most people, a decision is made. Now, we've kind of taken transplant out of that a bit, and transplant discussions can happen at any time in a patient that's considered at risk of progression. Because some of the information they're going to need about making sure they're well and ready for transplant happens way before their GFR is even at 25 mils per minute. So we've kind of reformatted to take that a bit out and to try to have people have those transplant discussions even before they're having their RRT orientation. Once they get to orientation, it comes again. But you shouldn't be sitting there saying, well, do I want hemopD or a transplant? I'm going to pick one, right? Transplant's always kind of up there leading the way, and most people, once they get to RRT orientation, if they were an appropriate candidate, should have an assessment done and should know if they're heading towards transplant. All right. So that's in terms of how we educate patients. In terms of what we do on the KCC side, one of the first things we did when we formed our group was to figure out for each of the modalities what is the kidney clinic responsible for, what is the receiving team, be it PD, be it hemo, be it home hemo, be it transplant responsible for. And it's really been helpful to have an algorithmic approach to what the KCC team is responsible for doing. So we, of course, identify the patients eligible for transplant. We do have a quite, and many of you are here to learn later in the afternoon what does eligible for transplant mean. I would say we err on the side of being probably a bit broad in terms of eligibility, which is likely good, but we may be able to narrow that down a bit with some further education. We provide a lot of information, so it's important that that information is accurate. The patients ask about the process, they ask about living donors, they ask about the risks, the benefits, the medications, the side effects, the follow-up, the lifestyle. So if any of that information is, I don't know, or unfortunately, or wrong, or I'll find out for you, that's not right. We are the pre-transplant clinic, right? We should have this information. So that is why many of us are here to learn that from the transplant program. And then one of the biggest things, when you have them in pre-transplant and they've already decided, that is a process. So many people, when you first mention transplant, they in the KCC side, they actually, yeah, whatever. And then they talk about PD or hemo. Like, they have to be convinced sometimes. There are the few people that are, they understand, they're motivated, that's the way they go. But others actually didn't really think of it as an option for them. So often our role is actually supporting them, going back to them, saying, remember that transplant option? What do you think about it? Why not? We still think it's the best treatment for you. That is a lot of what we do, not sitting down at one session and them picking their modality of the pick list, but re-discussing and re-explaining why. Just like if someone didn't want to take a medicine, you would explain, you'd bring them back, you'd explain, because this is the best treatment for them. Helps when you click your own computer versus a computer that it's not even on. This will depend whether what programs you're in, right? We some kidney clinics take on more of a role. In other clinics, it's more either the home team or the transplant referral center. I think you've talked about that a bit, but kidney clinics can and usually do initiate the referral in promise, organize the pre-screening tests. Some do all the vaccines, the consults, and we have in our algorithm a maximum time there of 6 months that can be tracked, and then submits the referral to promise. And we can talk after offline about how that's working and if we can make it better, but many kidney clinics do all of this. And then we help arrange any additional tests, consults. If the patient's not suitable, provide psychosocial, emotional support and discuss other options that are available to them. If they're suitable but no living donor identified, reaffirm the backup plan, but keep going with identifying donors. And if an accepted donor, we of course support the patient in preparation, help with travel, help with accommodation. Some of your smaller programs, you are the person doing it on both sides, but in others, you're helping the transplant program do that, and some transition counseling. So that's kind of the process of what we do in the kidney clinics. In terms of when we step back and say, why aren't we converting all of our potential patients? I think the elements essential that I think we can work on are the following, and I think these themes are found if you read the transplant literature of promoting preemptive transplant no matter what country you're in, and I think some of these are, we're kind of one step ahead. So one is engaging patients to understand their views, and that's what we did in terms of the education. Some things we say sometimes that we think are right, don't worry about the immunosuppression, they use really low doses these days. It's not that convincing, right? Sometimes that doesn't answer their question. Creating a culture of transplant first among the community, among the patients, among the professionals. And we have the Kidney Foundation doing it at community level as well. And we're here to make sure the patients and professionals know that. Understand the local population. So all of you will have your demographics, you'll have your cultural factors, you'll have, so know if you have a big Filipino contingent, know kind of how those patients think about transplant or Asian or others. And there's lots of work being done research-wise, but it's not that hard to have a focus group together and find out from in your area what themes come up. And then improving the patient understanding, which we're trying to do with the education, as well as the professional understanding, which we're trying to do here. So we surveyed our programs. We did it both at the KCC side, and then Claire helped us to do it from transplant, and thank you all for providing the information. And the information from that formed some of this session. And I'll just go through a little bit about what I found. So I've read through all of your feedback, and there were nurses and dietitians and social workers and nurse practitioners and physicians. And the main points were referral status of the patient, so where are they in the system, help with donor outreach, understanding the benefits, communication between programs, things like contacts in Vancouver, the donor process, the recipient process, eligibility, outcome data. So you'll see the themes in what's being presented today, because this is exactly what was asked for by all of you with respect to gaps. Not just gaps in terms of one meeting, though, gaps in terms of ongoing sustainable education and knowledge. So I think that's what we all have to do, and the KCC is working with Transplant over the course of the year to figure out how to do that in a sustainable fashion so that all staff coming on will have that. So just in conclusion, I hope to have convinced you that the KCCs are really on board to a preemptive transplant first philosophy and have started to make some strides in that direction, but there's more to do. The KCCs are the first introduction to transplant for the majority of our patients. So it's their first pre-transplant clinic, so we better set a good example. The standard pathways in education that we have created have started to increase the number of patients choosing transplant by about 70 patients to about 270 patients over the course of 2 years. The goal now, of course, is to convert those into patients with preemptive transplants from the kidney clinics. And I think we need consistent and sustainable patient, provider, and community education. And just as I closed, I was trying to say what, usually with our metrics, we have a goal. What would our goal be? So I don't know what our goal would be in terms of preemptive transplants, but right now we have 7% of our patients receiving preemptive transplants that start RRT. I challenge you I think we can double it. I think we can double it over the next year or so. It is a reach, but I think we can achieve it. So with that, I'll close and ask for any questions. Can we start with people in the remote sites? Any questions? Yes.
Part of the conversation that I've been hearing as well is the time constraints within the KCC clinics. Could you address some of that and how you work around obviously very busy clinics? How does that? How do you have these sessions, and maybe describe that a little bit more?
I think it's absolutely. So the question's about time constraints. I think they're real and they're a challenge. But in our zeal to be systematic in the kidney clinic, we also have to keep our eye on the prize. So we will pre-screen our patients, and maybe patient X, the only thing you're going to discuss with them that day is this. You're not going to talk about their phosphorus today. They've heard it, right? You're going to talk about that next time. Not that it's not important, but you're going to have kind of a multidisciplinary effort to talk to that patient about transplant those days. So it's not a complete answer. It takes a lot of phone calls in between. It takes a lot of kind of discussions on the side. None of these can be done in a systematic, you have 8 minutes in each room and you go to the next room, and that helps with kind of the keeping people in check and ongoing care, right? But it doesn't help with these big life decisions. Maybe it's just the social worker that day that sets another meeting to talk about their needs. So it's kind of taking them outside of the model with this goal still in place and saying what parts of the team are important to actually reach that goal at that time. I don't know if any others want to comment, because you all work in the clinics. Not today. Yeah.
Well, I think to some extent this is a bit of a culture shift, right? I mean, we like to say that we've been doing this for a really long time, making transplant first, but actually been lost thinking about other things for a while, right? And so I think we really can achieve this if we can just refocus on that goal and making sure that all the programs realize that they're all important to transplant. Not got isolated into a single nurse who did transplant on the side.
Excuse me, for the distant sites, unless somebody is mic'd or the comments are repeated, we have no idea what's going on. Thank you.
Okay. So I'll try to summarize. Really, we're confessing that in the kidney clinic environment, we have been distracted a bit with making sure all the other pieces are going. And since transplant was a separate entity, it was left a bit to that entity other than explaining it. And our reason for being wasn't as much to promote transplant and to follow through than it can be. So just an encouragement that we actually can make that shift, and I'll look forward to doing so. Any other? Hi, Mike.
Hi, Monica, it's Bobby.
Hi, Bobby.
Hi, just thank you. I think what I'm hearing from you is that we are funded for doing that options education and just ensuring that we're prioritizing. And part of that pre-screening is recognizing who are options for that and making that a focus.
Yeah.
Is that the message? I mean, that's what we do, right?
Yeah, I think that's the message. It used to be RRT was, a group of people, and you go through the four choices, and RRT has now, I guess it's RRT 2.0, where we figure out who the patient is, figure out how we're going to present it, in what order, not to leave anything out, but to really focus on the ones that are the ones that are the best option for them. Yes, hi. Can you press your, there's a little button.
Where's the video accessible, and is it accessible online
Sure.
to a broader group?
Yeah.
Also, in addition to that, are there any other tools that you're using in your KCC clinics, like educational checklists, or how do you communicate between the team members about who's doing what part and what may have been covered?
Mm-hmm. So first question is modality options available online. So if you just put modality options BC YouTube, the Renal Agency YouTube channel has it on in all the different languages, narrated and translated. If it's also on the Renal Agency website, and we can talk about having it linked back and forth to the BCT website, so it's available. We supplement, that is just kind of the introduction, so we supplement with, of course, all the great information from BCT, so all of the pre and post and donor process and all the recent ones that were done. We use all of those as well, but it's kind of the setting the stage document, and then we give them all of that stuff. But we also give it out on a kind of a URL when patients leave, if they want to show it to their family or their son or whoever happens to be there, so they can have options education as well, which has been actually quite well utilized. In terms of how we communicate standard checklists in the KCC, we've done the algorithm for transplant, but we have not done standard checklists for that. So we have for other things like conservative care, there's a checklist, and others. So we definitely could work with transplant to, it's not that hard to take the algorithm and make it in a checklist. Once they're referred to transplant, obviously the transplant module becomes a checklist, but before that, we just traditional charting, most of us, unless any other clinics have other tools.
The Kidney Foundation is going to do a better job of making sure that the kidney care clinic staff are aware of the LODERT program, because I know there are patients that don't even consider a living donor because all their family is overseas. And they don't understand that there's some compensation for travel and accommodation. And it really is an eye-opener for them when they realize that option is available.
I think the script actually has the loader in it as well, the facilitator's guide. So anything, you can also come look at the facilitator's guide, which is used to train new staff coming on. And then if there's anything else that could be inserted, that'd be a wonderful, wonderful time for dissemination. Yeah.
To go along with that, is there any plans for some of the savings that, from such wonderful kinds of ways that the renal agency has been able to plan out medications and stuff, any chance that more money would go towards covering costs of recipients? Because even, let alone out of country, but even inside Canada, certainly with people, I'm a social worker that I talk to, that's often a barrier to the living donor.
I'll defer to my transplant colleagues to answer where money would be deferred. We definitely can use money where money is needed, but it's probably outside my scope to answer that.
Well, unfortunately, the way health, just the way funding for healthcare is, that that's not something which the Ministry of Health will actually even come close to accepting us approaching, support for that. So if we're going to do it, it has to be through our partners like Kidney Foundation. But it certainly can't come directly from like Ministry of Health type of funding.
Identifying it as a barrier is important. We are going to have to be creative in how we figure that one out. Yeah. Mike.
So I had a patient who was a young guy who had FSGS and had declining kidney function for like 15 years. Predictably, we knew he was going to lose his kidney function. And I set him up for a living donor preemptive transplant, and I was like, yes, I got this one. And it all fell apart right at the end, and he wound up on dialysis. Due to kind of complicating features of his particular case. But I mentioned it because getting a person a preemptive transplant is like the most complicated organizational task that we have ever contemplated successfully doing. And I think we're seeing that in the statistics. It's very difficult. Even if we can see it coming and we do everything possible, it's very difficult to make it work. So the only reason I say that is because this is obviously a good place to start in the KCC clinics and to try and fine-tune our processes and stuff. But my comment is that maybe we should try to redefine what it means to have a preemptive transplant, because my stats just went awry there. But this gentleman's going to be on dialysis for maybe 3 months, and then he's going to get his transplant. So to me, that is a preemptive transplant, and I don't know if that's really captured.
Yeah, that's not captured in those that data, but absolutely that will be. I think we have a lot of work in data collection and presentation in that transition, and dialysis within the people that actually convert their donor within the first year. There's a lot of information like that and where it started, and those are important both to show you're actually to not get discouraged, and also to learn from where was the barriers. Were they actual barriers that could be overcome, or were they the fact the guy needed a cath and it put him into renal failure and then he got his transplant? So this is absolutely, you said it well, this is not an easy thing, but it's the best treatment. So we have to figure out a way.